So as was introduced, this presentation is navigating autoimmune health, understanding, identifying, and healing strategies. So I'll be talking about things that increase susceptibility to autoimmune disorders, how to help our patients identify their triggers, developing a roadmap for healing, and then suggested therapeutics. So as I just mentioned, as we were chatting at the beginning, I have had an autoimmune disease, and I personally know how frustrating it is when you're on the other side and you're a patient and you ask, well, why? What caused this? And we're told, well, we don't know. We don't know what the cause is. But the reality is, and I think when we work in functional medicine, integrative medicine, we don't have to have that response to our patients. We can actually say to them, well, there's usually a number of factors that come together. We know there's a genetic component, something from the environment has, triggered these genes. And there's also been some immune dysregulation, often involving, gut dysbiosis or something going on with the digestive tract. So we do understand this pathogenesis, this triad between the genetics, that susceptibility. So we need to have these genes, HLAs that I'll explain, that do produce these autoantibodies, and then these triggers through the environment and impacting our immune system. So when it comes to the genetics, we know that autoimmune diseases are polygenic, meaning that there are multiple genes coming together, increasing risk. The main genes that influence autoimmune disease are the human leukocyte antigens, or the HLAs. So in addition to the HLAs, though, there's often other genes that can increase risk, or in some cases even offer more so protection or reduce susceptibility. And we know from gene or genetic studies looking at type 1 diabetes, and I mention type 1 diabetes because there is a crossover genetically between celiac disease, type 1 diabetes, as well as thyroid autoimmune disease. So studies have shown that the more susceptibility genes you have, overall that increases risk. And if you are interested in that, the reference is down the bottom. So this Frontiers in Endocrinology, and this type 1 diabetes paper showed that the more single nucleotide variation, so the more SNPs they had, risk alleles could increase to an odds ratio of 61. So when it comes to the HLAs, these human leukocyte antigens, what they actually do is code for antigens or proteins that sit on the cell surface. And you can see that on the right-hand side. We've got that diagram there. So what they're doing is actually helping our cells recognize tissues, proteins and things that are meant to be there, that are safe, but also things that are non-self. So it's actually looking for pathogens, bacteria, viruses, things that can potentially harm us. So they present multiple peptides to our T cells or B cells or natural killer cells and secrete cytokines to control pathogens. The main function of the HLAs is to clear infections. So this is absolutely essential for the survival of the species. And when it comes to our HLAs, we actually have lots of different genetic variations. So we have lots, for anyone that knows a bit about genetic testing, when you look at these HLA genes, there is many, many variations along these. And this is actually really important because some of us will actually be resistant or protected against even novel viruses, novel bacteria. So these variations in the HLAs are really important for ensuring that we are able to mount an immune response very quickly to things that we've seen before, but also, as I said, novel pathogens as well. But occasionally these HLAs that are so important for keeping us safe from infections will target self-antigens, and that results in autoimmunity. But as I said before, when it comes to autoimmune disease, we are not just looking at our genes. The genetics are there, and that increases our susceptibility. We need to have these genes to mount this immune response, cause these antibodies that will then attack our own tissues. But there are other factors, such as environmental factors or endogenous triggers. So in the case of thyroid autoimmune disease, and I mentioned this because it's an area that I work in, as I said at the beginning, we have the HLA genes, and this really relates to any autoimmune disease, not just thyroid. So we have our genetic susceptibility, and the HLAs are generally the major susceptibility genes. These two following it, if you're sort of looking in this middle circle here under genetic susceptibility, the two genes below that are specifically linking with thyroid autoimmune disease, and then the vitamin D receptor. So we know that vitamin D and adequate levels of vitamin D is really important for helping regulate our immune system. And vitamin D deficiency is linked with increased risk for autoimmune disease, as well as cytokine genes affecting that inflammation. And then there can be environmental triggers, as we can see over here on the left, infections, exposure to chemicals and toxins. And when it comes to autoimmune disease, if we're looking on the right, women tend to be more at risk, and particularly at certain time points. So post-pregnancy, also around menopause or after menopause, women, particularly for thyroid, tend to be more susceptible to autoimmune disease. So I did mention this before, autoimmune thyroid disease, which is what I'm mentioning here when I say AITD, autoimmune thyroid disease. This is including both Graves' and Hashimoto's, type 1 diabetes and celiac disease all share common genetic susceptibility with those HLA class 2 antigens. And I'm sure many of you listening, even if you don't do the kind of DNA testing I do, would be looking at celiac susceptibility. And if you do see these celiac-related HLA genes, we know that these people are also at increased risk for other autoimmune diseases as well. So there's a lot of overlap between these HLAs. And if we just look over on the right, just to help picture these HLAs and what they're doing, you can see this antigen presenting cell, APC, so this sort of pink one here. And then coming out of that, we have that HLA, and it's recognizing this peptide, those red peptides, amino acids coming together. So that's representing, part of the thyroid sequence. So this is obviously self. The HLAs should really only be recognizing non-self viruses, pathogens, things that get into the body that we want to attack. But in some cases, we have particular HLAs that will recognize a peptide or an amino acid sequence that's in gluten, or that's actually naturally part of our thyroid. And when we have these HLAs that recognize that, we take these in, we present them to our T cells, our immune cells, and then we mount that immune response and can start making antibodies that will then attack in this case, the thyroid or whatever that may be, or gluten. When it comes to other genes increasing risk for autoimmune disease, aside from the HLAs, and I know that some of you also do DNA testing, just to inform you, I'm always looking at FUT2. This affects gut health, has been linked with microbial diversity in the gut, as well as risk for IBD, so as well as psoriasis and autoimmune diseases, but mainly with gastrointestinal disorders, Crohn's, irritable bowel, etc. So fucosal transferase 2, if people do have this genetic variation, and you can see an RS number there over in the right, RS 601338. Even if someone has done Ancestry or 23andMe, I'm generally recommending to do other types of DNA testing, but you can usually have a look for these RS numbers. If you are an AA, you're a non-secretor, you're not secreting these fucosal molecules, you're not making these oligosaccharides or these antigens, And because of that, it is affecting, the gut microbiome, and that obviously affects the immune system, linking with this autoimmune disease risk. The other gene that I pay attention to if I'm thinking about immune health, chronic inflammation, autoimmune disease, is tumor necrosis factor alpha. So this particular SNP, you can see the RS number here. This has been associated with almost every autoimmune disease. Now, it doesn't increase risk to the same extent as the HLAs. So those HLAs are the main risk factor for autoimmune disease. If someone has those and you identify that in your patient, they have a high risk for autoimmune disease. The tumor necrosis factor alpha, sitting at the top of that immune cascade, is really turning on lots of cytokines. So what this means is that the person is going to have a very strong immune response, like an exacerbated immune response. I call them pro-inflammatory. And that's not always a bad thing. Someone having a really strong immune response is great if they do have an infection and they need to fight that. But obviously in this day and age, often our immune system's turned on with stress, or on top of that, we might have some nutrient deficiencies that mean, for example, vitamin D or zinc, that are impacting our immune system. And that's when we start to get these issues and this immune dysregulation. So for those of you that get excited about genetics like I do, don't worry. I know some of you won't want all of this information, so I won't go through this in detail, but this is a review I wrote a few years ago and published, where I actually looked at a lot of genes linking with thyroid autoimmune disease. Some of the testing companies test them, but some don't. But this actually it's a really good review. We've got tons of references, trawled through the data and looked at the genes that do increase risk for either Graves or Hashimoto's. Some of them you're probably familiar with. FOXC1 is in a lot of the testing companies, and that is one that is linked with hypothyroidism. But it's not just about the genetics, as I said before. If we're looking at this graph here on the horizontal axis, vertical, so vertical going up, we've got our epigenetic risk, and then down the bottom, horizontal, we've got our genetic risk. So someone might have the genes, the susceptibility genes for autoimmune disease. However, if they don't have those environmental triggers, whether it be a toxin or an infection or the stresses, they are likely to not go on and get an autoimmune disease. But when we have the epigenetics and the genetics come together, and when I say epigenetics, I'm really talking about the environment. So we know that things like BPA is a hypomethylator. It rips off these methyl groups. Chemicals and toxins, stress changes our epigenetics. So these things influence the genes that are turned off and on. So it really is the environment. And you can think back to that saying, and I wish I could think of his name. People say this all the time and forget to reference the original person, or I've seen other people take the claim, but that saying where it says genes load the gun, environment pulls the trigger, is really true here. And that was published in a book a very long time ago. So again, just giving the example of thyroid, but this could represent any autoimmune disease. These triggers that we talk about that are going to affect the epigenetics or be the factor that really pushes someone post that sort of threshold, or where their body becomes out of balance, are things like chemicals, heavy metals, deficiencies of key nutrients. I've mentioned vitamin D a few times. Vitamin A is important, as I'll explain. Missing some of these trace minerals. Zinc is a cofactor for hundreds of enzymes. Selenium working with our glutathione peroxidase as an antioxidant, as well as lifestyle, smoking, alcohol, etc. And stress really should be added in there as well. So moving on to identifying these triggers, helping our patients work out which of those things that we just talked about relates to them, and then helping them work through that so they can hopefully undo their autoimmune condition, go into remission, and start to, really feel truly well again. Because obviously with the mainstream medical model, as we all know, particularly when it comes to thyroid, and I know this from the doctors that I've seen, they're quick to just say, it's fine, we can treat it. It's not about looking at these underlying causes. But the reality is when we treat it, let's say with Hashimoto's, they've got thyroxine, or Graves, we're having the thyroid removed and then having thyroid hormones. We're not fixing the problem. And often people still feel awful. They're still exhausted. They've still got other symptoms going on. So what to look for: genetic profiling, which I obviously do, but also food sensitivities and nutrient deficiencies. Have they got an infection? Is it a chemical or a overload of toxins? Have they been experiencing chronic stress, or has there been a traumatic event that they need to work through? So when it comes to diet, we want to remove any of the triggers. For example, gluten may be a trigger, or things that are affecting their gut health and slowing them down from improving their gastrointestinal tract, improving their immune system, and adding in as many healing foods as possible, focusing on a nutrient-rich diet. And I've got here adequate macros and micros. And what I really mean by that is, are they getting enough protein? I work with a range of different people, but a lot of women, in the fertility space, which was the first 10 years of my life, fertility, now doing a lot in the autoimmune, thyroid, and also healthy aging. But particularly with the healthy aging, there are many people, men and women, that just aren't getting enough protein. So we need these protein for healing, for tissue repair, but also all of the enzymes, and also just maintaining that muscle mass. A lot of people want to lose weight, they want to lose fat, but we want to keep that muscle. So are they getting enough protein? So one of the first things to think about from a dietary perspective, if someone has an autoimmune disease, is considering taking them off gluten. Because I do DNA testing, I will look for, and many of you that even don't do the full profiles, you can obviously test for if they've got the HLAs. And if I see this, I'm more inclined to tell them to try to really reduce gluten, for at least 4 weeks. If they don't have the HLAs that are linked with celiac and gluten sensitivity, that means they will not ever get celiac disease. They will not develop those antibodies to gluten that will affect the digestive tract. However, it doesn't mean they might not have gluten sensitivity. You can have non-celiac gluten sensitivity. If they've had long-term dysbiosis or some kind of, trauma in the gut, they've got leaky gut, intestinal permeability, they could be sensitive to lots of things. And we know that those proteins in gluten can be quite inflammatory. We know that gluten can increase zonulin, so those sort of tight gap junctions can be affected. All that work by Alessio Fasano that clearly shows that. So even if they don't have the HLAs and they've got autoimmune disease, they can still think about reducing gluten for a little while to help the gut heal. But if they have the HLAs, educating them that they may want to consider having a low gluten diet for life, particularly if they want to go into remission and they don't want that autoimmune disease to come back. So I provide a lot of information around gluten. I do run a 4-week whole food challenge so people can take out gluten, giving them lots of swaps. And in some cases, we'll talk about reducing dairy as well. In addition, we want to look at, obviously, history. Symptom questionnaires can be really helpful, particularly if you're not doing a lot of testing. We can get a lot from symptoms, blood testing as well, urine and stool analysis. If I'm working with my autoimmune patients, with most of them, I probably will get a stool analysis as well. And over here on the right, I'm just giving an example. This is kind of a summary page at the beginning of the report that I use. So I use a lab here in Australia. I'm not sure who you use over there in the Philippines. I used to use doctor's data. You might be using doctor's data, but I'm now using a local lab here in Australia. But you can see in this case, it's just an example. Someone actually does have an infection. They've got slight, calprotectin inflammation, and down the bottom, borderline microbial diversity. So, suggesting that we really do want to work on their gut health. Food and mood tracking. And now more than ever, I'd say this is pretty new for me, really in the last year or so, I have started asking people to, and my system that I use actually can connect to some people's wearable devices. And I'm interested in, I've always been interested in sleep patterns, but now I'm also looking at their HRV and trying to help them improve that resilience, because that's also a good indication that they are, getting well and recovering from that autoimmune condition. So when it comes to developing a roadmap, I really like doing a timeline. And in my autoimmune thyroid program, I actually do have a 12-month reversing autoimmune disease program. I'm in the process of shortening that, even though I think it can take 12 months to truly go into remission, solidify all those habits, get antibodies down. I've learnt firsthand a 12-month program is too long for people to commit. But part of that, we will do a timeline. And I know that many of you, particularly in the Philippines, I'm not sure about in Hong Kong, but I know the Philippines, you had IFM training because I came over to Manila for that. I tend to use one that's just a little bit more simple than the IFM one, and just get people to, and they do this as an exercise. They have a video and they do this themselves rather than me doing it. Like with IFM, obviously you're sort of noting it down. You create the timeline. I get my patients to create it themselves. And this can be a really powerful exercise for them to start to really put down all the things that led to that time point when they got a diagnosis or they started getting sick. So obviously there's the prenatal things. If they know that their mother perhaps had an exposure to a chemical and toxin or some stress, or any issues with the father, he's obviously, giving 50% of the DNA along with his epigenetic patterns as well. If there are certain genes, if they've done testing, do they have certain HLAs putting them at risk for autoimmune disease? So finding out that, and then mapping out all the things that led to that particular, time point where they really felt like they lost their health. And I know on a personal note how healing this actual exercise was for me. It took me quite a few years to probably put it all together, really. But when I started to understand this, I almost got to a point where I was able to let go of a lot of the guilt and shame that comes with being sick. Because particularly as a practitioner, but really anyone, when you have a chronic illness and there's something wrong, there's this shame, or you feel like, you've done something wrong. Why me? At times it can be victim mode. You're blaming all sorts of things. But when you can write it all down and say, well, there were these things in my early life, and then I was burning the candle at both ends, and then I found out I was vitamin D deficient, and this happened, and I was living in a house with mold, and then I got this infection, and whatever it may be, whatever that individual's timeline, it's almost an aha moment where you go, well, no wonder I got sick. So rather than feeling angry and blame and victim mode, it's like, okay, this actually now makes sense. And I think as human beings, we actually want things to make sense. We're trying to understand what's going on in our body. And even if it's not every single thing, it's starting to help them understand and piece that pieces of the puzzle together. And I know for me, it was a big weight off my shoulders. When I sort of put it all together, I was like, oh, like no wonder. And now I know what I have to work through, and definitely what I'll never do again, or what I'm going to avoid, or how I'm going to try to live my life to make sure that I get well and that I stay well. So this is something that I've put together recently. You may or may not want to take some of this, or if you're sort of new to putting these programs together, put something similar together yourself. You might already have something. I'm very happy for you to share what you've got as well. But I very recently this year have put together what I'm calling the DNA connection method, obviously geneticist, DNA, but first step, detect, where we do these health assessments, questionnaires, the timeline development, all the testing. And then once we've sort of got to this detect, working out what's going on with the person, with their biochemically, their hormones, stool analysis, whatever it may be, then putting together this protocol. And this is what I'm calling Nourish. So the dietary, the supplements, sleep and mental health issues, and then aligning this with their lifestyle and their long-term goals. Often people are really busy even though we want to exercise a certain amount of times per week. It's just got to be realistic for what works for them. Setting people up with a support network. Do they need a personal trainer to keep them going with exercise? Do they need a counselor or a psychologist because of some trauma? Do they need someone else in their support network to ensure that they truly get well or they're getting the support they need? And putting together these personalized roadmaps for our patients. And I think when we can map this out and they know they're coming on board, particularly if it is a program, because it can take quite a while for our patients to go into remission, and they know that there is this path that helps them understand, because it can take time in some cases. I mean, with Graves, as I'll show you in my case study, I think we can reverse that pretty quickly. And I'm pretty confident, 3 to 6 months for Graves, depending on the person. But some autoimmune conditions can take a little longer. So when it comes to the nourish side of things, as I said, we take out trigger foods, but definitely a lot of education around sugar and refined foods. We know that's inflammatory, definitely not good for any chronic conditions. And then also about foods that can really help with gut health, so prebiotics and fiber. When it comes to the supplements and we are wanting to really improve our patient's immune system, get them out of that autoimmune state, I'm really thinking about vitamins, A, C, and D, the omegas that are anti-inflammatory, curcumin, and in some cases, quercetin. I like quercetin because I have a few sort of hay fevery histamine things. So if someone has a histamine issue, I definitely bring this in. When it comes to vitamin A and vitamin D, these are absolute key players in regulating our immune system. And I wanted to show you this. It was published in Nature Reviews. It's quite an older image. And I've done some talks with autoimmune health with you before, very different to this one, but I have shown you this slide before if you've come to some of my earlier talks. But for those who haven't seen it, or just as a reminder, we have our vitamin D that comes in and enters our immune cells. I'm looking at the left over here, that sort of orangey one there. We've got that macrophage. So vitamin D will come in. We've got that 125D there, so the active form of vitamin D, and it binds to the vitamin D receptor. Now, genetically, some of us have SNPs in the vitamin D receptor and it doesn't bind so well. These people, we need more vitamin D, and in some cases, even things like sulforaphane, certain NRF2 upregulators will help upregulate the vitamin D receptor. But that 125D will bind to the vitamin D receptor as well as the retinoid X receptor. So with vitamin D, we need vitamin A as well. It's the vitamin D, vitamin A receptor complex that's important, and that binds to a section on the DNA known as the vitamin D response element. And that goes on and turns on all of those immune genes, or regulates our immune system and helps with reducing chronic inflammation and reducing our risk of autoimmune disease. But over on the right, it's not just about vitamin D needing vitamin A, that retinoid X receptor. Vitamin A can actually bind to that retinoid X receptor too, and we do have vitamin A response elements. And in this example on the right, we're looking at cells in the gut, immune cells in the gut, and we can see that it's vitamin A turning on these important immune-related genes. So when it comes to vitamin A, this is one of my favorite nutrients. Personally, I realized I was deficient in this when I did have a flare, even though I've recovered from my immune from Graves. A few years later, I got pregnant, and then post-baby, doing too much, traveling, doing talks, thinking I was living my best life, but probably a bit too much with a little baby, getting off stage to breastfeed and traveling around thinking I was super mum. I had a bit of a flare with my thyroid, but at that time, I also developed psoriasis, which tends to happen with autoimmune disease. If you get one, you can get another one. And I definitely educate my patients about this too. When they come to me, I say this is not just about helping them deal with the autoimmune disease they've got now. We're also preventing them from the other conditions that tend to follow once you've had one diagnosis. But I got psoriasis, and definitely my skin was not good at all, but vitamin A was a game changer for me. The thing with vitamin A is it's a bit difficult to test. I'm not sure if you do vitamin A testing. I'd love to know at the end. Feel free to share that with me. When I say difficult, it's because there are so many different forms, sort of the beta carotenes, the retinols, and things like that. So I think the symptoms can be enough. So with the symptoms, are they having acne or pimples? Have they got rashes, dermatitis, psoriasis? It's so important for the mucosal membranes. Are they susceptible to infections? And then the big one being night blindness. Now, I had this. So in the evenings, I was avoiding driving, didn't even consider vitamin A. It was obviously many years ago. But when I started taking vitamin A, it was a game changer for my vision, for my skin, and obviously now something I really pay attention to, particularly for my autoimmune clients. So we have our dosages there. Vitamin A is one of those things, though, that I don't tell people to stay on, forever. I mean, I never really tell people to stay on supplements forever. But with vitamin A, I generally tell them to, have one bottle. Sometimes people go away and they just take supplements for a long time. But with vitamin A, I make it really clear. I'm like, just have that bottle. Perhaps it's either 3,000 IU, or if I think they need, much higher, depending on symptoms, they might have one of the higher doses, 10,000 IU. I'll have that. And then at the end of that, make sure you check in with me and let's discuss these symptoms, skin, vision, etc., whether we think you need to stop. But most of the time I'll do it, for just that few months. And then if they're having symptoms again down the track, maybe, but it's not a long-term supplement. And if they need it, they generally get an improvement pretty quickly. Vitamin D, though, is one of the supplements I don't mind people being on long-term. Often they need to be, whether they're having just a standard dose, just a sort of a maintenance dose of 1,000 IU, or if they need higher doses, 5,000 IU, if we find out they've got lower blood levels. In Australia, 5,000 IU is actually a relatively high dose. I know in other countries, some people do much higher doses. In New Zealand, for example, our neighbours, they do 50,000 IU once a month. In the US and some of the other Asian countries, they do 600,000 IU injections. I'm not sure what is common for you. I think you're more similar to Australia. Let me know in the end. But yeah, we are generally 1,000 IU is a standard dose. And if we need to give more, we don't tend to do much more than 5,000 IU. Unless someone's really low or needs it, we might go to 10,000 in the odd case. But when it comes to vitamin D, this is one where I do like to do testing to determine levels. And I'm looking for at least or somewhere close to 100 nanomole per litre. And that's, just above or 40 nanograms per mil for the US measurements. And this PLOS-1 study suggested that possibly we might even need closer to 120 nanomole for optimal immune function. What we do see, though, is between that 100 to 150, it does seem to be really beneficial for our immune system. We tend to lose those benefits after about 150 nanomole. So it's not necessarily more is best. We have this sort of like a J curve. So we want to keep within that optimal range. So vitamin C is also really important. I'm sure most of you are giving vitamin C for immune health, particularly if we're thinking about, winter, coughs and colds. I know when I do my traveling, international traveling, I always take vitamin C with me. Standard dose being, 1,000 milligrams, but in some per day or a gram. But in some cases, people will have much higher than that. We know if people have high doses, they can get, nausea, they feel sick, or perhaps even, loose bowels. So this is another slide that I have shared with you in the past. If you have attended, I think it was quite a while ago now that I did the autoimmune talk for the Philippines or Hong Kong. I think it was about 3 years ago, 2020 or 2021. I don't think we have any updated research. If anyone's seen it, I'd love to look at it. But comparing liposomal, with oral and IV as we have here. But this is a good study. And what we can see over on the right, if we're looking at the graph, we can see that sort of dashed line with the open triangle. That is the IV, intravenous vitamin C. And you can see that if you have IV vitamin C, that obviously gives us the highest levels very quickly. But for many of us, we might not have the ability, might not have a nurse or someone doing IV, or someone like myself now. Since COVID, I now work online with almost everyone. So in those cases, when I was in the medical practice, we had an IV clinic, but I'm not there anymore. I'm working from home and online. But I don't think we necessarily need to do that. Maybe in some unique cases, you might want to do that, but I'm now a fan of the liposomal. And what we can see here in the bottom graph is what you can see when we kind of zoom in, the difference between our liposomal, which is the black triangles, and the open circles being the unencapsulated. So that's just the standard oral vitamin C. Is that liposomal, being the encapsulated, does give higher levels. And as I said, I like vitamin C, particularly just as a bit of a immune protection when I'm doing a lot of my travel and I get the liposomal vitamin C. So I said another one, quercetin. So D and A are often the first things I'm thinking about when I'm thinking about, trying to help someone recover from an autoimmune disease. But when we're thinking about supporting immune health, particularly if there is some, sensitivities, asthma and allergies, and, I said hay fever, rashes, histamine-related things, thinking about quercetin. Again, this is something that I've had a lot of success with and will suggest to people rather than having, an antihistamine. Obviously, it can be found in foods, but the reality is the dose to get that therapeutic effect, we do want to have higher amounts, which we get from our supplements. So the other thing that needs to be considered with autoimmune disease is most of the people, almost everyone that has come to me that does have an autoimmune disease, has an extreme element of fatigue, exhaustion. And that often is linked with, adrenal issues, stress. So rest and relaxation is absolutely essential. Sleep hygiene, and even I'm not sure if you give recommendations about how long to sleep, but often these people need to sleep a lot longer for a little while. I know when I was recovering, I really needed to sleep a long time. Now, if I wanted to sleep, I'm happy if I get 8 hours. That would be amazing. But back then when I wasn't well, I could sleep 10 hours and I would still just be absolutely exhausted. I mean, the body needs to repair, needs to rejuvenate, it needs to heal. And that's going to happen when people are sleeping. Reducing caffeine. So we know that caffeine obviously triggers a little bit of cortisol, a bit of adrenaline. Some people may be a bit resistant. Of course, we work with them. But if they really do want to recover from an autoimmune disease, I think reducing caffeine can be a game changer and actually really help with energy. It's so counterintuitive. You think that the caffeine's actually giving you energy, but when people really come off it properly, it's much better for sustained energy. They might need adaptogens if we're thinking about stress, or you've done a Dutch test, or you're looking at cortisol, and obviously the B, C, and magnesium for helping adrenals and stress as well. Magnesium and Bs too are definitely something that I give a lot of my patients. The adaptogens, it depends on the person. And when I say adaptogens, I'm thinking about ashwagandha, rhodiola. So the other consideration from a supplement perspective, particularly if it's someone with thyroid autoimmune disease, or in this case, Hashimoto's, I'm very cautious with iodine in all thyroid patients, but particularly Graves, I'd only ever give iodine if they came back deficient, and particularly if they're thinking about having a baby. We know it's so important for fetal brain development, and I do mention this in the case study. But selenium being so important, zinc, iron, and amino acids like tyrosine being a precursor to make our T3 and T4. And the last one I want to mention is zinc. So when I'm thinking about those key immune nutrients, aside from A, C, and D, thinking about zinc, we know that it's important for both our innate and adaptive immune response. Some people might be giving much higher doses than this. I seem to be getting a lot of people coming to me these days that have been on 50 milligrams of zinc for a really long time. Even a few years ago, when there are a lot of, immune, infections and things, people are on 100 milligrams of zinc. My only concern with that is we do need to consider that ratio with copper. But I tend to, if I'm thinking about immune support, I'm thinking 20 to 30 milligrams. The reality is too, if you are having a very high dose of zinc, most of it won't be absorbed. We do have studies looking at absorption, and we know that the higher doses we give, we actually turn down, like we do with iron and folate, our receptors are down-regulated and we don't absorb that much anyway. So this is just a good review looking at zinc and autoimmune disease. So a meta-analysis here. And if I just skip down to the bottom, basically says that, where are we? I thought I had a little text box having this here, but we can see from out of 179 articles, I'm kind of going to the middle of the paragraph here, 179 articles, 62 satisfied the criteria. And what they found is that zinc concentration, both serum and plasma samples, were linked with autoimmune disease. So they were significantly lower. So our zinc levels were lower in people with autoimmune disease compared to controls. So definitely something that we want to consider. So I'm just going to move on to a case study. Now, this is someone that I didn't do a lot of testing with. When I say testing, generally I do a lot of genetics, functional testing, but in this case I didn't. But we still had great success without even going to that level. So she was 32. She'd had one child. She had family history of cancer on both sides, thyroid disease on her mother's side, and she had been diagnosed with Graves' disease, but prior to that had long-term immune health issues, getting sick quite a lot. She said that she had a really weak immune system, and she really wanted to improve her health. She wanted to have another child in future, and she was really worried about this. So when it came to diet and lifestyle, actually, it wasn't too bad. She had a relatively good diet, eating vegetables, fruits, a bit of meat, pasta, sometimes. When it came to sensitivities, she was avoiding chili. Sometimes she would sort of get a reaction, but no other food sensitivities. Drank water and tea, no coffee. So she sleeps 7 to 9 hours, but says she doesn't wake feeling rested. As we go along and I get to know her better, I don't think she really was sleeping the 7 to 9 hours. She's got a little one that was sleeping in her bed sometimes. And also she went to bed very late herself, but then would be getting up because her little one would get up in the mornings. Her stress was a 6 out of 10. That stress was really about having a healthy pregnancy in the future, worrying about the Graves, raising a child, first-time mum, stressful job, and she did have quite a traumatic birth experience. So her bowels were once every third day, which I thought was very interesting. With Graves, everything kind of speeds up. People tend to have loose bowels, frequent bowel motions during the day. I definitely did. But she had actually had constipation since she was a teenager. And when she had Graves, she said she was going twice a day. But when she came to see me, she was on medication, so anti-thyroid medication, carbimazole, and was back to every third day. So she walks, and I always ask people about their relationship with their food. She said, I love food. I've always had a sweet tooth. I do enjoy a bit of junk food. I've always eaten well, such as meat and veggies. I do have control over my eating. When I was little, I was a picky eater and underweight, and she is not overweight and has never been overweight. So she had a number of supplements in the past, but when she came to see me, she was just on vitamin D. She'd had many antibiotics during her childhood, teens, and as an adult, and she was on carbimazole, and this was 3 times a day for 3 months. However, she had just become hypothyroid. So this is a very recent diagnosis. So she had dropped down to only 1 carbimazole per day based on becoming hypothyroid, which was detected with her bloods, as I'll show you. So in October 2021, if we're looking at the top left, we can see her TSH is, not detected. She's got that high T3, T4. She does have positive thyroid antibodies. CRP was 10, white blood cell count was low. So there was lots of other blood tests done too, but I'm just sort of showing you the white blood cells, the CRP, things that came up. So definitely showing that she's hyperthyroid and has antibodies there for a diagnosis of Graves in October 2021. So in December, she was given those 3 tablets. She responded very quickly. Her T4 and T3 have come down, but her TSH was still low. So I think because of this, the doctor didn't change the medication when probably should have been done here. And I was the same. I went very hyperthyroid, and I actually got quite big. I went from being so skinny to extremely overweight. I was hyperthyroid for a while. It's definitely throws you around. So then in January, she became hypothyroid. TSH is high. Her thyroid hormones are low. And that's when her medication was changed. And then she came to see me. So on that 1 anti-thyroid, 5 milligrams of carbimazole, that 1 tablet, her TSH, her T4 and T3, I put normal there. It's so-called normal with the reference range. I wouldn't say it's optimal, but she's definitely stabilized here. So she's responded very well, very quickly to the medication. Despite this, because the doctor was feeling that she needed to see a specialist, which made sense, she was sent to the endocrinologist. But the endocrinologist said, despite, as I said, responding well to the medication, that she was booked for a total thyroidectomy. So when she got to me, she said she really didn't feel comfortable with this. Her GP was willing to support her, but she just wanted to know, was there any options? Is there something she could do? She knew that I had actually her, not her GP, but I think it was an allied health, maybe she's actually a physio herself. I think it was a physiotherapist or someone that had seen me, had referred her to me. So at the start, I just said to her, thinking about, chemicals and toxins, things in our water. So, educating her about the things that in our environment that impact autoimmune disease. So filtering her water, trial going off gluten and added sugars. And then I said I wanted her to discuss reducing her medication with her GP. I didn't know her GP. So I do work with a lot of doctors, have a great network, but in this case, I didn't know her GP. But as I said, her GP was really supportive of her doing what she felt was right and exploring this option and not necessarily jumping into the thyroidectomy. So I said, speak to your GP about reducing your medication to 5 milligrams every second day, depending on what the next lot of blood results were. So when it came to the next bloods, we can see that she's definitely getting a little bit hypothyroid. So without a doubt, it was an easy decision. So we dropped to every second day for about 4 weeks and then asked her to test again, which she did, and things improved. So she really wanted to get pregnant. So in addition to starting to reduce the medication, I said to her, I think you should go on a multi. The only issue was the iodine. I said to her, because she actually was about to start a preconception multi, and I said to her, just go with half a dose. The one I gave her recommended 2 tablets per day, and that would have given 150 micrograms. So this way it would have only been a smaller dose. But I said to her, she needs to test her iodine levels straight away, because we just want to check if she actually really needs it. And I come from my own personal experience here. So I was told, I had children after I recovered from Graves, and I was told I could not take iodine. But I actually know how important iodine is for brain fetal development. So I come from a background of fertility. My postdoc was obstetrics gynecology. I work mainly in the methylation folate B12 space, but I did a lot of work with Creswell Eastman. He's our big iodine researcher here, and we've actually done a lot of sort of co-presentations on optimal nutrition and supplements for pregnancy. He actually was one of the people that really got our clinical guidelines changed to make iodine 150 micrograms mandatory, like folate is for pregnancy. So I had deep understanding of how important this is, and that if you have low iodine in pregnancy, you have a baby with lower IQ. And in Australia, I'm not sure about Philippines and Hong Kong and there in Asia, but in Australia, we'd actually seen that our IQ was going down over the years as our iodine levels went down. So I tested my iodine. I was low, and I decided to have a prenatal, but I edged up very, very slowly, because we know that iodine can trigger those thyroid antibodies. It can even happen in Hashimoto's. It's not just Graves. We need to be really cautious with the iodine. So when it came to sleep, as I said, as we went on, we realized that she was going to bed quite late. So told her to try to work on her circadian rhythm, seeing the light first thing in the morning, getting a really good nighttime routine, that sleep hygiene, to try to improve her sleep. I also wanted to look at homocysteine, a marker of methylation, and her vitamin D levels. So when it came to September, obviously she's reducing her medication, but this was still looking good. Her antibodies had come down. They still were positive, but had come down significantly. So that's such a good sign. So I suggested dropping to twice a week. Again, testing her thyroid in 4 weeks' time. So being really cautious, a really slow approach, and trying not to fluctuate the thyroid too much, which is what she'd already been through, and so many people do with Graves. So here are her bloods in October. And then we had her urine iodine. She was borderline low. So I said to her, we definitely want to have a prenatal with a little bit of iodine. It's really important for the baby's brain. But again, we just need to be having lower levels for a bit of time, because it's the higher amount. It's a big increase of iodine that will cause that reaction. If it's just a little bit of iodine, we don't see those sort of increases in autoantibodies. Her vitamin D wasn't too bad. Ideally, we'd have it a tiny bit higher. And then her doctor also did her folate and B12. So I said to her, because she'd been on the prenatal for a while, she could increase to that standard dose. So it's not that we're doubling it, that's just the standard dose. We added in a probiotic. So thinking about her bowels, and what I didn't mention to you too is that we'd spoken about a bit of psyllium and fiber, and I said to her it's really important she's using her bowels every day. She had been given folic acid. I didn't realize this by her GP. So I told her she didn't need that. The prenatal I gave her actually had a little bit of like methylfolate. And because it was summertime, I said to her I wanted her to get outside, rather than increase the vitamin D, try to get that naturally than the supplement. So when it got to 7 to 9 months, she was off her medication completely. Now, I think some of you are in my Facebook group, and if you are, you know who this is. She's come in and done a couple of chats with us. She was over the moon. At this point, honestly, she said she didn't think she'd ever felt this good, as in her energy. She'd noticed a change in her hair and her nails. We can see here her thyroid levels for January, and then March, actually looking slightly hypothyroid. And she actually, sorry, not hypothyroid, her TSH in March went down, and she was very concerned about this. She came back to me really concerned. So she fell pregnant really quickly. I actually sort of told her to wait. I didn't think she'd fall pregnant instantly, but she did. But then, as per normal, as we know, TSH levels do drop in pregnancy with their lowest point at about 9 to 12 weeks. So I told her not to worry about that. Yes. So then we went on, and this is not the best. I sort of scanned this in, not the best example here, but I've just put that in here so you can see that her TSH did go up. So we've got here 1.10. I'm circling this. I'm not sure if you can see my cursor, but if you go under thyroid function and then you go the TSH, you can see it's 1.1. Her free thyroxine went down. She actually came back to me and said the midwife was thinking about giving her some thyroxine. I said to her, really don't think that's a good idea. I think everything will balance out. And it did. So she went on to continue to see me. And this was October last year. Just a little message here. Hi, Denise. Hope all is well with you and the family. Just letting you know I had my baby born 3rd of October. We're so in love. Feels like a dream. And I can't say thank you enough for all your help and support. It wouldn't have been possible without you. So she, came in and chatted to us in my group to share her story. Didn't tell people she was pregnant to start with because she was less than 12 weeks. So I have Your Genes and Nutrition community. It's like a free Facebook group, and sometimes there's practitioners or patients. Sometimes I answer questions. She came in and just said about, as I said, this sort of health overhaul, how she just felt so much better. Couldn't believe she was in remission. The doctor, the endocrinologist, has said to her she needed her thyroid out. She wouldn't recover. But then she came back into the group, surprised everyone because she didn't tell them she was pregnant, that she had the baby. So she's doing really, really well. And I have to say, when you talk about taking on a practitioner's advice, after having her baby, she just said to me, I really want something with gluten. I haven't had anything with sugar. She said, I've been baking with all these other, things. And I said to her, you can have I didn't realize she'd actually been 100% off gluten the entire time. And I said to her, you've done such a great job. I said, you can have a tiny bit, see how your body responds. But perhaps I hadn't explained it properly in the sense of, reducing the antibodies, but she thought if she had a bit of gluten or possibly even sugar, that, she would go back to that space of having Graves. So I've said to her, she can relax a tiny bit, doesn't have to be that obsessed because that causes more stress in itself. So in summary, autoimmune disorders result from a complex interaction between susceptibility genes and environmental exposures that alter epigenetic patterns. So thyroid dysfunction is common, and taking medication in the case of Hashimoto's or destroying the thyroid gland for Graves does not heal the person or the condition. And for those who are willing and motivated, and not just for thyroid autoimmune, but any autoimmune disease, to change their diet, change their lifestyle, give them the supplements they need to correct, deficiencies. This can help with reducing those autoantibodies and obviously improving health for lifelong, reducing chronic diseases as well.